The next case is 55-year-old male Pashupati, diagnosed with open distal radius fracture right side, posted for debridement and pinning, which is done under subclavian perivascular.
So,
Professor Chan,
okay,
you're on to the auditorium, sir.
all right. Good morning, everyone. I'm asked to demonstrate how to do a supraclavicular brachial plexus block. So what I'm using is a linear probe, high frequency. It is important to know what the indication for this gentleman is the distal radius fracture. Supraclavicular brachial plexus block is very good for Dr. Brian Size called the spinal of brachial plexus block. It's very good for anything in the arm, in the elbow, in the forearm, and all the way down to the hand. So the important thing to do is when you do the scan, I am right on top of the clavicle, but it's important to know the angle. If I just put it on top of the clavicle and angle this way, I would not get a very good image of the subclavian artery. So I have to keep turning until I get a good image of the subclavian artery, and it's pulsating in the middle of the screen. Also important to remember is you want to make sure you don't cross the important structures, right? The bony structure, you want to make sure the plexus is on top of the first rib. So right now over there, you see a very bright line underneath is dark. That is the first rib. As opposed to the right side of the screen, you see it's also a bright line, but it's hazy. Air artifact underneath, that's pleura. So when I do a scan, I want to make sure the plexus is on top of the first rib and not on top of the pleura. Just in case if I miss the needle tip position, I may go into the pleura, so I don't want that. So the first rib will be a good bony structure to stop your needle. As I said yesterday or the day before, it's very easy to see the plexus here. Most people, I think in your patient population, you can see it very well. But the key here is to have to see where the needle tip is. Otherwise, you may go too far and then you get into a pneumothorax situation. So what I see here is the plexus. You expect it to be lateral and posterior. So you see that the plexus is now on the left side of the subclavian artery. That is the lateral side. So this is a medial lateral orientation. Now if I turn my probe anterior posterior, or slightly oblique, you can also see it right next to the subclavian artery. So it's not just one way of doing it. You can do this approach. You can also angle the probe anterior posterior. So here it is a bunch of grape-like structure. It's very dark, a bunch of grapes we call it. And you see the hypoechoic structures. It's important, first of all, I use color to make sure that they are all nerve structures and not branch of the subclavian artery. So because oftentimes you see branching of subclavian over here, the dorsoscapular artery, for example. So I'm going to ask you to use a color, okay, just to make sure all those dark spots that you see, they are all nerve structures. So I'm happy with that. So this plane will be a good place to do the procedure. Another thing people always ask is, do you see the trunks? Because here you're blocking the superior and middle inferior trunk. You see a whole bunch of structures there. So either you are seeing the trunks or you're also seeing the divisions when you scan more distally. In order to recognize it, all you have to do is go back up to the low interscalene area. So look at the top of that bunch of grape-like structure. When I go up, the superior trunk, now you can see the C5 and C6 nerve root. The C5, C6 nerve root that you see, so you see three big round structures, 5, 6, and 7. So 5, 6 will go together. I'm scanning distally now. 5 and 6 will go together, and now that's the superior trunk. So right now what I see here is, I would say superior trunk, middle trunk, and now inferior trunk is not as distinct. oftentimes you don't see it as this thing, and we call it corner pocket. So right now it's right next to the subclavian artery. It's important to block the inferior trunk if this is for hand surgery. Otherwise, you miss the medial part of the hand. But if it's for elbow, I will put more local anesthetic in the medial trunk. And some people will even use this supraclavicular block for shoulder analgesia because the superior trunk is right there. So for me, there are many approaches of doing this block, but regardless of what you do, make sure you can see the needle tip. For me, I do an in-plane approach. I'm going to go from lateral to medial. And as I go in, I'm going to hydrodissection. And I follow the needle tip. And I want to go into a pocket, distend the space, and then go down to the inferior trunk. Now I'm going to use my left hand for my needle. If you are not comfortable with your left hand because you're right hand dominant, then you will be standing at the head of the table and use your right hand for the needling. So that is how you would do it. And the machine obviously will be on the other side at the foot of the table. But with time, I'm sure you will all be very good, and you will be able to use either hand to do it. So what I'm going to do we use any local for the skin? So usually I use some local for the skin, but if the practice here is not, then so this is a block needle. This is a 2-inch, 5-centimeter needle. Usually that's enough because you'll notice that the plexus is only 1.5 centimeter deep. So it's very superficial in this case. The other thing I do is I purposely put the probe over here so that the plexus is close to the edge of the screen. Once the needle is in place, then I will shift the probe over the needle. So I start over here. I'm going to put a little bit of local anesthetic now, a little pinch.
Professor Chan, how do you decide on the entry point of the needle, whether it will be flushed with your probe or you do like to go?
I leave a little bit of a gap between the probe and the needle. I have seen people getting too close to the probe, and then what happened is they leave a needle mark on the probe, so I don't like that. So generally speaking, I put a little bit of a small gap, less than 1 centimeter between the probe and the needle insertion site.
Okay.
So now I'm going to go in. I aim to do an in-plane approach. I go through the skin. Then the next thing I do is I'm going to shift the probe over my needle. Right, so I can see the needle here. I think this is an echogenic needle. This is they are very kind to me. They give me an echogenic needle, so it shows very well. My goal is to put the needle at about not exactly close to the first rib. I go a little bit above the first rib, so I know I need to increase the angle. I want to see the needle better, so now you can see the needle quite well. And also I ask my assistant to inject maybe half a mil of local anesthetic, and you will see the expansion. So if you cannot see the needle tip well, that helps you to tell where the needle tip, approximately where the needle tip is. And then again, you should either move your needle or move your probe in order to see it. So now I'm going to go in a little bit more. Okay, so I'm very close to the plexus now. So what I want to do again, a hydrodissection, a little bit of low distension. Okay, so I see where I am. So I'm very close. I'm just pushing against the sheath. So what I want to do is very controlled now. I'm going to go in a little bit, and oftentimes you feel a pop. Okay, another hydrodissection. If I'm really impinging on the sheath, it's very hard to distend. And notice that the spread here is away from the plexus. Can you repeat that? just a little injection. See that the local anesthetic is not going into the sheath. So now I have to pop through it. So very controlled. Another hydrodissection for me, please. It's very resistant, right? So let's very control. See how close I am to the artery. So I don't want to obviously get. Can you try again? So whatever you do, do it slowly. You don't want to hurt the patient at all. Is it difficult? Okay, so I think it is still, I'm still not too happy.
Professor Chan, why is that you're not still happy?
Because first of all, I don't feel that I'm inside that compartment yet. I don't feel that there is a gift. I'm very close to the artery and the first rib. Obviously, I don't want to go through either of those structures. Can you try and hydrodissect again? Okay, so I'm still not. Okay, give me 2 cc there. No, I'm not happy. So I'm going to do something slightly different. I want to go in the plexus first. Puncture the sheath. Okay. Do you see that? Do you see the push?
Yeah,
okay.
Yes, that's right.
Can
so here's the sheath now.
The sheath, I'm inside the sheath now. Can you give me half a cc? Okay, that's good. So you see very different, right? So I'm now trying to go down to, can you give me another 1 cc there? Open up, yeah. So let's now look at the needle. So I have changed my plan. Initially, I want to go straight to the corner pocket and puncture. But I really worry about if I go in that direction, I will either hit the first rib or the subclavian artery. So that's why now, after I go more superficial, Kefalette, I now go back down to the inferior trunk area. Can you inject 2 cc there? Okay, good. So I think now we can do incremental injection.
Professor Chan, how much do you normally inject for your...
For this block, I have not reduced the local anesthetic dose or volume, because if you want this to have a surgical block, you still need at least 30 to 40 mils. I think for your population, you probably need about 30 mils. That should be quite good in order to get the good anesthesia.
What's the local anesthetic that you normally use?
That's what local anesthetic? I usually use half and half. Now, before I go further, I've injected about 12 mils. Okay, so I'm now going to look at the spread. I don't want to inject everything and realize that is not going to the right place. So I'm going to scan proximally now. So I'm scanning proximal. You see local anesthetic surrounding the nerve roots. Do you see that? There is a dark area surrounding the hypoechoic nerve root. I'm going more proximally the interscalene groove. So I'm looking for haziness around the nerve roots. So that tells me that, yes, there is spread proximally. Can we get rid of the, hide the arrow? Push the hide button. No, the up, yeah, hide, yeah, that's good. So now I'm going back to where the needle is, and I want to finish the injection there. All right. Can we inject another, finish that injection, and I will give another, oh, hold on, stop. Can you spray? But I think it's an artifact because I don't get any blood at all. Okay, so can we inject another 2 cc there? So now the needle has gone, I think it's now between the middle and the inferior trunk right now. So we finished the injection here, aspirate, make sure no blood. But if you see the expansion, you know that it is not intravascular. So I'm going to come out. The aim is to give total of 30 at the most. I'm going to come back a little bit. I want to get to the middle trunk. So the middle trunk is right there. Can you inject half a cc? Okay, that's good. Another half cc. Okay. Can you inject half cc again? Okay. Can you give me 5 cc there? How much have we injected so far?
Just 3 cc left now.
Okay, we'll finish it here. Okay. Give another 3 cc there.
You want to finish this?
No, just that should be enough. How much have we? This is 30?
Yeah.
Okay.
It's 150.
We'll finish it.
Should we give it to you?
Yeah, I'll finish it there. That's good. Thank you. So again, have a survey of the area.
Be careful.
Be careful. So this is post-injection. You see a lot of local anesthetic in that area is surrounding the nerve. The nerves are no longer closely packed together. They are further apart. Right. So this is what you expect to see afterwards. Now if you go up further, you can see local anesthetic in the low interscalene region. And oftentimes if you go infraclavicular, you also see it because the local anesthetic has spread proximal and distal.
So that's the pectoralis major, this is the pectoralis minor, and you see the artery there.
So again, you see local anesthetic, a little more depth. You can see the local anesthetic surrounding the cords now. So you can, again, this helps you to decide how effective the block is, how far the local anesthetic has spread. So this, I'm happy with the spread.
Do you, to see the tip of the needle, when you use sonosite, do you use the multi-beam?
Usually I leave that on. Right now the multi-beam is on. Some people would even use the needle visualization software. Personally, I seldom use it because now you already have given me the echogenic needle, so I don't need it. For anything that is deep, if I really have a hard time seeing the needle, then yes, I will use that option. But the multi-beam, I always leave it on, is the compound imaging.
Excellent demonstration of the subclavian perivascular or supraclavicular block. Is there any questions to Professor Chan? Yeah, there is a question to you, Professor Chan. Dr. Sajish from Trivandrum wants to talk to you.
Yes. Hello.
Good morning, sir. Sajish here. My question is, sir, how do you avoid this thing? What your technique, modification of technique to avoid the dorsal scapular artery?
Well, the dorsal scapular artery, when I scan it, I don't see any branching. Can I have a little bit of gel? I don't see any arterial, any vessels crossing. So if I do see the crossing of the dorsal scapular artery, then I will scan in a different plane in order to avoid it. So always check with color to make sure no crossing of any vessels. There are veins, there are also arteries crossing, and oftentimes you may even see it goes between the superior and the middle trunk.
Most of the time it's between the superior and middle, it comes out. And you go more inferiorly, or?
I usually go more inferiorly, okay. Yeah. Okay, so for example here, you can see the artery, and now there's a branch coming out. Can you use color now? Right? That is the artery coming out. So you can see it's coming out, coming out, coming out, coming out, coming out, coming out, and now is no longer in my plane. So I know that when I do the procedure here, I am not crossing any artery. So that's how I would do it. So always find a plane that there is no vessels crossing. That will be, in my opinion, a safer approach.
A little above the clavicle, most of the time we will feel the dorsoscapular artery, but the safer one is go more inferiorly, but always the problem with the pleura.
Well, the pleura again depends on how you scan, right? If I scan like this, you can see the pleura here. You can also see the pleura on this side. So because it's the first rib is like a curve, so you can see the pleura on each side and the bone. So usually, if I have this issue, I would just keep scanning more anteriorly. Now the plexus is on top of the first rib. Or you can also turn the probe a little bit oblique if that helps, so you can check in different direction. So that again, the plexus on top of the rib as opposed to the pleura. What I do not accept is if I see that, for example, I cannot really demonstrate to you. For example, here I don't like it because the inferior trunk is now on top of the pleura. So I keep turning. Now it's on top of the rib.
Yes, thank you, sir.
You're welcome.
Any other questions to Professor Chan? Professor Chan, you have one more question.
You are using in-plane technique. What is your opinion about out-of-plane technique for supraclavicular?
I don't do out-of-plane technique. I know that at this center, this is accepted practice. My message is, whatever you do, if you cannot see the needle tip, do not advance the needle. Otherwise, you can get into trouble. So whether it's out-of-plane or in-plane, in North America, most people would do in-plane because they can see the needle tip and the needle shaft easier. But I know, again, there's no one way of doing it.
But out-of-plane technique using hydrodissection.
Yes.
What is your opinion about it?
I like hydrodissection. I use it to help me to open up the space. And also I use it to tell me as a surrogate marker a further signal of where the needle tip is. So I do that all the time.
So there one more question, Professor Chan.
Yes.
Yeah, give it. Anga, doctor.
So if there is a surgery of the lower end of the radius fracture, do we have to have only a supraclavicular block, or you should combine it with an axillary block?
No, this is quite good. You really do not need to combine with any other blocks. The only time that I fail here is to miss the ulna, the medial side.
Yeah.
If I check if that really is not enough, then I can supplement more distally. But this block actually is very, very reliable. Very, very reliable. So I usually do not need to supplement.
So if it's a lower end of the ulna, then also, or?
Yes. Anything in the hand, supraclavicular, perfect. As long as you also block the inferior trunk.
Thank you.
You're welcome.
Yeah, one more question, Professor Chan.
What about the tourniquet? Will the patient be comfortable with the tourniquet with this block?
Yes. Even with axillary nerve block, I have stopped doing intercostal brachialis block for more than 10 years. Has never been a problem since I stopped. So to me, it's a myth. I have not done it for 10 years.
But Professor Chan, do you use intercostal brachialis block for surgeries of the proximal humerus and the shoulder?
Yes, that will be different, but I'm talking about the tourniquet.
Only for tourniquet, but
yeah.
Okay, sure, yeah. So thank you very much, Professor Chan, for a lovely demonstration. And I think we should give a round of applause to Professor Chan for that lovely demonstration.